How can we tell if one thing is causing another? Historically, people would blame unusual events on supernatural causes. In European folklore, for example, infants who were born with 6 fingers were known as exchanged children. People believed that a witch had come in the night and swapped the child for one of their own. But not everyone saw it that way. In 11th century Persia, a physician named Ibn Sina suggested that this condition of having extra fingers or toes wasn't supernatural. He argued that these kind of situations and others in medicine had underlying natural causes. His ideas showed how medicine could be more rigorous, moving from simple stories based in superstition to scientific analysis of cause and effect. That shift from stories to science is the same shift we face today. Every time we ask a question like, did this treatment work? Did this exposure cause the harm we're seeing? Suppose a patient takes a new drug and then they get better. Did the drug help? Or would they have recovered anyway? The problem is that we only get to see one version of reality, the one that actually happened. This is what's known as the fundamental problem of causal inference. We want to infer whether one thing has caused another, in this case, whether the drug caused the recovery, but we can't rewind history and observe what would have happened if the patient hadn't taken the drug. Sometimes the benefit of a treatment is so large and quick that even ad hoc observations will give us the correct conclusion. This was the case with insulin for diabetes and vitamin B12 for anemia. But most of the time, things aren't so straightforward. Factors like age or underlying health conditions might influence both the chances that a patient gets a drug and the chances they recover. This complexity makes it hard to separate cause from coincidence. So how can we do better? In 1947, epidemiologist Austin Bradford Hill and his colleagues set out to test streptomycin, a new drug for tuberculosis. Bradford Hill knew firsthand just how bad TB could be. He'd contracted it while serving in the First World War. It nearly killed him and left him with only one working lung. This time though, he wasn't just tackling the disease, he was tackling the problem of how to treat it effectively. One option to test the treatment would have been to just alternate patients between treatment and control as they arrived in the clinic. But Bradford Hill had noticed biases in previous studies that had used this approach. He suspected doctors subconsciously changed how they managed patients, knowing that treatment would only be given to every other one. Bradford Hill and his colleagues instead randomized who got the treatment and who was in the control group. The team created a set of sealed envelopes, each containing a random assignment. S for streptomycin, C for control. No one in the hospitals knew what was inside until a patient was enrolled. Even the radiologists looking at the lung x-ray to diagnose TB weren't told which patients had received the drug. When they revealed the results, 29% of the control patients had died within 6 months. In the treatment group, just 7%. In other words, a 3/4 reduction in mortality. It was the first modern randomized controlled trial in medicine, and it marked the beginning of a new, more rigorous way of testing interventions. The logic behind a randomized controlled trial is simple. A whole range of factors influence disease severity. But if we randomize who gets treatment, then on average, these background factors will influence both treatment and control groups in the same way. So we would expect any difference between the groups to be down to the treatment on average. But what happens if randomization isn't possible? Take smoking. In the 1950s, lung cancer rates were rising. Cigarettes looked like the obvious culprit. Smokers were 9 times more likely to die of the disease than non-smokers. But not everyone was convinced. Ronald Fisher was one of the most prominent statisticians of the 20th century and a keen pipe smoker. He argued that just because smoking and cancer were correlated, it didn't mean smoking was causing cancer. Smokers might have other lifestyle factors that explain the difference, or maybe a genetic trait that made people more likely to smoke and more susceptible to lung cancer. A randomized trial would in theory have given the answer, but of course, we can't just randomly make people take up smoking to test whether they would get cancer. Not only would this be unethical, it would also have taken a long time to give an answer. Thankfully, Bradford Hill and others found alternative ways to assess whether smoking was causing cancer. He would later outline a set of viewpoints to help assess cause and effect in situations where a randomized controlled trial isn't possible. First, we should look at the strength and consistency of the link. For example, smokers are much more likely to get lung cancer, and we see this pattern across different studies and locations. Second, we must consider the timing and how the outcome scales with exposure. Does smoking often come before cancer? Are heavier smokers more likely to get cancer? Ideally, there would also be evidence from an experiment. If people stop smoking, it should reduce their chances of cancer. Finally, we should think about whether the explanation makes sense biologically and how the idea fits with existing knowledge. Do the chemicals in smoke cause cancer in other species? Does the theory contradict existing science? Bradford Hill didn't present these viewpoints as a checklist or a way to prove causation definitively. Instead, they were tools to help scientists weigh the evidence and to answer the crucial question: is there a more likely explanation than simple cause and effect? Since then, researchers have applied these ideas to a whole range of other problems. For example, in recent years, analysis of millions of health records has pointed to Epstein-Barr virus as a cause of multiple sclerosis. Infection with the virus was linked to a 30-fold increase in subsequent risk of the disease, and the same pattern wasn't found for other related viruses. When it comes to estimating cause and effect, it can be difficult to be 100% sure. There are always other possibilities and other potential explanations, even if these are very unlikely. It can be tempting, if we're faced with this inevitable uncertainty, just to sit on the fence indefinitely. But Bradford Hill warned against waiting for certainty if current evidence suggests a major risk. There's always a small chance that in future, new evidence will emerge and we'll need to update our view. But that doesn't mean we should ignore the evidence that we already have, especially if it strongly suggests we could prevent a lot of harm by taking action.